Hello, coders, and welcome to part 3 of medicine. So part 1 started at our immunoglobulins and vaccines and finished where the cardiovascular surgery picks up. Part 2 is all about the cardiovascular procedures and ended in the peripheral arterial disease. And this is now picking up on page 654 in your code book at the home and outpatient internalized normalized ratio INR monitoring services. So again, we've got some revised guidelines for these, and we also have, or actually they're new guidelines, I should say, and new codes. And you'll notice that, again, anticoagulant management used to be an evaluation and management. And so this is something that's different because this is home monitoring. So they tell us, home and outpatient INR monitoring services describe the management of the warfarin therapy, including ordering and review and interpretation of new INR test results, patient instructions, and dosage adjustments as needed. Again, if you are performing a separately and significantly identifiable E&M service on the same date, then you can, in fact, use 93792 because that's the patient caregiver training with an E&M code. But 93793, which is anticoagulant management, cannot be reported on the same date. Okay, it also can't be performed in conjunction with telephone, online, or other outpatient INR monitoring services. All right. So again, for this one, we can look under INR monitoring services. See right here, patient caregiver training for initiation of home INR monitoring and anticoagulant management again. So we have to keep in mind, which one of these are we doing? Are we doing training? Are we doing the management? Remember, management is going to involve the paperwork that goes into adjusting the medication, taking the test, ordering the test, and the timing of the tests. The next section goes on to non-invasive vascular studies. Again, one of the more interesting aspects about medicine is it has a lot of ultrasound in it, but it's mainly of the cardiovascular system. So we saw already some of the cardiovascular services, but those were mainly going around the heart. Now we're dealing with the vessels. So again, what we need to be careful for is where are we in the body? Because again, for these, are the vessels, are we looking in the arms? Are we looking in the legs? And we have guidelines for limited versus complete studies of these ultrasounds, just like we do in radiology. So again, these studies include the patient care required to perform the studies, supervision of the studies, and interpretation, again, of the studies with copies of the patient record, of hard copy output, with analysis of all data, including bidirectional vascular flow or imaging when provided. Okay, so again, what we're doing is we're looking at the blood flow through the vessel, whether it's an artery, a vein, or both. Now, reminds us that the use of a simple handheld or other Doppler device that does not produce a hard copy output or that produces a record that does not permit analysis of bidirectional vascular flow is considered to be part of the physical examination of the vascular system. It is not separately reported. So starting probably about 10, maybe 15 years ago, there was a medical company that came up with an ultrasound probe that you can attach to a smartphone. And you can do a little ultrasound like bedside or right there in the office. However, the differences between that type of contraption and a normal ultrasound equipment is that the handheld is something that does not produce a permanent record. Remember, ultrasound has to produce a permanent record. The other thing that most of these devices do not do is does not allow you to look at the vascular flow. It just looks at the physical structure. So again, we have to be careful on how they're describing this. Now again, for the duplex scans, so again, they tell us the duplex scans, we're looking at the characterization and pattern of the direction of blood flow in arteries and veins with the production of a real-time image integrating B mode for brightness, two-dimensional vascular structure, Doppler spectral analysis, and color flow Doppler imaging. So again, B is for brightness, two-dimensional. So again, we're going to be able to basically kind of see almost like if it was a cross-section of the length of these vessels. Now again, the Doppler spectral analysis and the color flow Doppler are different ways of looking at the vessels. And so this is being able to differentiate, excuse me, the flow of the blood through the arteries and veins, and also to get a better look at, if, for instance, we're looking at the vein, those one-way valves in the vein. So getting a better look at these. It also goes on to tell us that physiological studies are performed using equipment separate and distinct from the duplex ultrasound imager. So again, physiologic studies are different, and they're telling us that these codes describe the evaluation of non-imaging physiological recordings of pressure with Doppler analysis of bidirectional blood flow, plus thermography and/or oxygen tension measurements appropriate for the anatomic area studied. So the physiological studies are looking basically more at the blood flow and the blood pressure and going in and out. So again, we're mainly dealing with our extremities. We're dealing with arteries, we're dealing with legs, we're going down to the fingers, we're going down to the toes. And so again, we're looking for what might be the physiologic issue. There could be a blood clot, there could be a vein where the valves have collapsed on each other. So again, the physiological study is looking at the physiology, the physical structure, and the blood flow. Now again, they're telling us for the lower extremities, okay, so this is ankle, brachial, and again, so where are we going for all of these? So it has to include the ankle brachial indices at the distal posterior tibial and anterior tibial and dorsal pedis arteries. So again, this is at the ankle and at the arteries going down into the foot, plus bidirectional Doppler waveform recording and analysis at 1 to 2 levels, okay? Then it could also be ankle brachial indices at posterior tibial, anterior tibial, dorsal pedis arteries plus volume plus thermography, or it goes on, it's the same areas with transcutaneous oxygen tension. So again, we need to know exactly what we're doing. What type of test are we doing? Because that will match us up with the type of ultrasound. Okay, then they tell us for the limited upper extremities, again, Doppler determined systolic pressure or bidirectional Doppler waveform recording, or Doppler determined systolic pressures in volume plus thermography, or again, Doppler determined systolic pressures in transcutaneous oxygen tension measurements. So again, what are we doing? How involved is this procedure? And again, it goes down and continues the complete studies for what are we covering. And then again, describing that alternatively, a complete study may be reported with measurements at a single level if provocative functional maneuvers, like measurements within postural provocative tests or measurements with cold stress, are performed. So again, extra information of what's included. Remember, our ultrasounds always are going to tell us the difference between the limited and the complete. So always go back and make sure that we're matching up all components of ultrasound so we know which of the codes to use. Then we get to the cerebrovascular arterial studies. This is also known as a transcranial Doppler study, okay? And again, includes the ultrasound evaluation of the right and left anterior circulation territories and the posterior circulation territories to include vertebral arteries and the basilar artery. Okay, so again, they tell us that in a limited TCD study, there's ultrasound evaluation of 2 or fewer of these territories. So for it to be complete, we need to make sure we go into the right and left anterior and posterior. For the limited, we're only doing 2 or fewer of those. They're also telling us the specific code 93895 includes the acquisition and storage of images of the common carotid arteries, carotid bulbs, and internal carotid arteries bilaterally with quantification of intima media thickness, which is the common carotid artery mean and maximal values, and determination of presence of atherosclerotic plaque. And this is what's important. They do this to a lot of people who are at risk for having strokes. And again, we're talking about the vessels that are going up the neck and feeding into the cerebrovascular area. So again, we're looking for plaque, and we're looking for any other buildups. So that's what they mean by the intima media thickness. Okay. So we're making sure the blood flow is appropriate for those areas going up to the head. Again, we're going to see some extremities. Again, they include our digits, so keep that in mind. We also see some visceral and penile vascular studies as well. And so again, what type of study are we doing and what best matches with it? Then we get to the pulmonary system. The first thing we see is ventilator management. So again, these are people that are on a ventilator or a respirator. Again, it's the same machine, just two different words for it. And again, we have hospital inpatient observation services and also nursing facility, as well as home ventilator management care. So again, where is the patient? So if the patient is in the hospital or they're in observation or a nursing facility, we code per day. If they're on a home ventilator, again, this is oversight services, paperwork. Goes on to tell us that codes 94010 to 94799 include laboratory procedures and interpretation of test results. Again, there can be a separate E&M code at the same time. So for instance, if a person is coming in for a yearly physical and they say they've been having problems breathing and they do spirometry, then that is something that we can code separately. But again, always make sure you're using modifier 25 with these services so we get paid the proper amount. Now, it goes on to give us some information about some very specific codes. Spirometry, which is when we're measuring how much air the person can get out as fast and as forceful from their lungs. Again, measures the expiratory airflow and volume, informs the basics of most pulmonary function testing. So if you don't do well on those, then other spirometry may be done. So again, we also have spirometry is performed before and after administration of a bronchodilator. So we have that. So for instance, if someone's getting a breathing treatment and nebulizer treatment, okay, the spirometry is included before and after the bronchodilator. Why? Because we want to make sure the dilator worked, that opened up the lung capacity. Again, we also have measurement of vital capacity, and that can be performed alone depending on what the doctor wants to do. We also have a flow loop volume, and that's when, again, the inspiration and expiration. We have the patient breathing in and out to see if there's any obstruction anywhere. Now, again, spirometry includes maximal breathing capacity, which is 94200, and flow volume loop 94375 when performed. So again, you have to be careful what's included in some of these studies. Goes on to tell us measurements of lung volumes may be performed using plethysmography, helium dilution, or nitrogen washout. And again, it depends on what the patient's showing as, what the provider wants to do, because the helium and the nitrogen can show them what the function of the lung is and possibly what the problem is. It goes on to say plethysmography is utilized to determine total lung capacity, residual volume, functional residual capacity, and airway resistance. Nitrogen washout or helium dilution may be used to measure lung volume, distribution of ventilation, and closing volume. Impulse oscillometry assesses airway resistance and may be reported in addition to gas dilution techniques. So again, we want to be careful. What are we doing for the patient? Okay, it also reminds us that the fusing capacity is most commonly performed in conjunction with these and is an add-on code. So again, just letting us know, be on the lookout. Again, we have a separate set of pulmonary function tests for young children through 2 years of age. So we have through 2 years of age and then over 2 years of age, because again, it's two reasons. Number one, the lungs are one of the last organs to grow in utero. And so if a baby is born premature, they might have issues with fetal lung immaturity. Also, it's more difficult to get young children to understand what we need them to do, such as spirometry. You know, when the child gets to about 2.5, 3 years old, you can explain to them, breathe out as fast and as hard as possible. But getting a 1-year-old or a 6-month-old to do that is not nearly as easy. So they do get paid a little bit more because, again, it's a little more complicated. Now, again, pulmonary function testing measurements are reported as actual values and as a % of predicted value by age, gender, height, and race. Because, again, those are some of the differences that pulmonology has found as, we've been learning more about how the lungs function over the last 50 to 100 years, is that they've been able to say, okay, these are what we assume for people in these different categories. We also have things like chest wall manipulation for the mobilization of secretions, and an improvement of lung functions can be performed using a manual or mechanical techniques. Manual techniques include cupping, percussing, and the uses of handheld vibration devices. So these are ways for basically to get people to be able to cough up the secretions that are inside their lungs. And so again, there's different ways they can use their hands and different devices that kind of vibrate to help the lungs expel whatever that is, or they can use other mechanisms to do that. And so again, how they're performing these procedures is just as important. So again, what specifically are they doing? So again, we have spirometry here, doesn't have an age, but then we have measurement of spirometric force expiratory flow in an infant or child through 2 years of age. So again, we need to be careful. If it's an age issue, if there are 2 or under, we have to look for the age codes. For the rest of these, we're looking at what is the specific test and what's included in those tests. And again, be on the lookout for the do not reports, okay? Now, the next section is allergy and clinical immunology. Okay, so there are actual allergists out there, and a lot of times before they become an allergist, they might be an ear, nose, and throat doctor or something like that. But it is a subspecialty, and a lot of times when we're dealing with allergy and clinical immunology, we're sending them out to the specialist. However, you might end up working for that specialty, so we need to know what they're talking about. So immunotherapy, which is also known as desensitization or hyposensitization, is the parenteral administration of allergenic extracts as antigens at periodic intervals, usually on an increasing dosage scale, to a dosage which is maintained as maintenance therapy. Okay, so let's say, for instance, that Bobby is allergic to dogs. So Bobby's parents want him to not be allergic to dogs, okay? So what we do is we send him to an allergist. The allergist does a consultation, confirms that it's a dog allergy, maybe looks into other possible mammalian furry animals such as cats and rodents and other things like that. And then there will be a discussion between Johnny's parents and the doctor on whether or not they want immunotherapy. And what immunotherapy does is the allergist sets up intervals. So sometimes it's once a month, sometimes it's once a week. Usually it starts out around once a month. And the person will come in and they will get an injection of the allergenic extract into their abdomen. And they will do this, and what will happen is over time, the reaction to the parenteral administration should go down, and then that's usually when they start increasing how often the patient comes. So it can also go the other way depending on what the specific issue is. I can have them come a lot in the beginning, taper off towards the end. These can take months or years to do. So that's something to keep in mind, is that, you know, these are things that these are not simple, easy 1 or 2 times. This patient is going to continue to come in on an average basis that's set up by the provider. Now, the other therapies that we might deal with are things like electronic devices, precipitators, air conditioners, air filters, humidifiers, dehumidifiers. We might also deal with climatotherapy, physical therapy, occupational and recreation therapy. For all these, again, we're going to see evaluation and management services. So keep in mind that a lot of times, again, they could be doing an office visit or a consultation first, and then decide to have the person come back in for the immunotherapy. Okay. Now, the biggest thing is, again, do not report the E&M service unless it's completely separately and significantly identifiable, and always use that modifier 25. So the first thing that usually happens is 95004. This is usually the first test we're going to see. So it says percutaneous test, scratch, puncture, prick. I've had all these done. The first time I went, I was a teenager, and I was having an allergic reaction to bunnies, guinea pigs, gerbils, things like that. So they did the test, but they also added in things like cats and dogs and a lot of the most common allergies around where I live for indoor and outdoor. So the first thing they did a scratch test. So they kind of scratch you with the different extracts, and then they wait, usually about 15, 20 minutes, sometimes up to a half hour. So the reason why it says specify number of tests is because, again, if we know the person is definitely not allergic to something, we're not going to test them for it. But again, when someone has one type of allergy, they may have another type that's very similar. So for instance, if someone is allergic to grass, we may also want to test them for things like hay, right? And the same thing, like I was just saying, for the rodents, so they tested me for rodents, but they also did cats and dogs and things like that, because again, they're all very similar. So it's going to be things like 95004 times 15. I believe I had 15 tests on the first time. And that's okay. That's completely acceptable. Why? Because on the diagnosis side, you're going to be able to explain why we did so many tests. Other codes we're going to see, again, we have the intracutaneous tests. I've had this done too. This is a little bubble that they put underneath. And again, they wait and they let you see what the reaction says. There's also things like patch or application tests. So again, this is something when they can't figure out what the person's having a reaction to, what they'll do is they'll ask the person to grab a sample of everyday objects that they use at home and at work. So this is everything from soaps and shampoos and detergents. It's also, especially if they work in the medical field, the gloves they use, if they use tape, whatever it ends up being. And what they do is they put this on a big patch, and they usually stick it on the patient's back for about 24 hours. And then what they do is they can take it off and see where was the reaction. And this is especially helpful for people that are allergic to certain additives that are in a lot of things like shampoos and soaps that are not easy to identify without these tests. We also have ophthalmic mucous membrane tests, indirect nasal mucous membrane tests, again, with inhalant bronchial challenge testing. So again, dealing with what gets inflamed. Some people get hives on their skin. Some people go into anaphylactic shock and have their throat close up. Or does it make their eyes water? Or does it make their nose run? Or their nose stuffy? Or does it make them have trouble breathing? These are all different ways we can try to figure out how the allergen affects the body before we figure out how to treat it. We also have ingestion challenging. These were added just a few years ago in 2013. And again, these are for things that we ingest that are, again, hard to figure out what might be the problem. So they tell us that 95076 and 95079 are used to report ingestion challenge testing. Report 95076 for the initial 120 minutes of testing time, i.e. not physician face-to-face time, they're usually with a technician or nurse. Report 95079 for each additional 60 minutes of testing time. For total testing time less than 61 minutes, so positive challenge resulting in cessation of testing, meaning they had a reaction that we had to stop the testing, report an evaluation and management service if appropriate. Now, the patient assessment and monitoring activities for allergic reaction, again, are things like blood pressure testing, peak flow meter testing. These things are not separately reportable. However, intervention therapy, if the person has a reaction, such as the injection of a steroid or epinephrine, may be reported separately as appropriate. Because again, someone could have a small reaction like hives on their face, or someone could go into anaphylactic shock and need epinephrine. So again, what's going on, but time is a factor here. And so again, that's what we need to know. So it's a food, drug, or other substance that we ingest. For the allergen immunotherapy, so now these are when we know what the allergen is that the patient has. So we have a couple different types of services that we need to be on the lookout for here. Because sometimes if it's something relatively common, such as like ragweed or pollen from the local area, the allergist will keep that in stock. But if, let's say, someone is desensitizing themselves to their own dog, they actually a lot of the times will have a special formula made at a pharmaceutical company that they will then either pick up at the pharmacy and bring to the allergist, or that will be directly sent to the allergist. So what we need to know is the allergist providing the allergenic extracts, okay? So codes 95115 to 95199 include the professional services necessary for allergen immunotherapy. Office visit codes may be used in addition to allergen immunotherapy if other identifiable services are provided at that time. So if it happens to be the patient's yearly visit with the allergist and they're getting an allergen extract, we can code separately for that. But keep in mind, so starting at 95115 and 95117, this is not including provision of allergenic extracts. So this means that it was either sent to the office itself and the patient paid separately for it through a pharmaceutical company, or they picked it up at the pharmacy and brought it in. Again, single injection, 2 or more. 95120 going down to 95134 includes the provision of the allergenic extract, but these go by how many? So we have 1, 2 or more for the allergenic extracts. It also goes on to the next page. It goes single stinging insect venom as well. So again, that's another reason why someone might get this allergen immunotherapy. If, let's say, you have someone who wants to be a biologist, okay, and they want to study the animals that live in the desert of the American Southwest, okay? Well, there are a lot of venomous animals there, including scorpions. So that person may go through allergen immunotherapy as part of their job so that if they do get stung while they're out there and they can't easily get back to healthcare, it won't affect them as badly. We also have codes for, again, the preparation and provisions. So again, if we're preparing them in the office, we need to know, again, how many vials are we creating. Or for doing stinging insect venom, again, supervision and preparation. So again, what specifically are we doing? So always keep in mind, are we giving it to the patient? Are we providing it? Are we not providing it? Are we preparing it? Okay, so what are we doing for the patient? Now for endocrinology this year, they have revised and given us a new code to describe this. Now this endocrinology is transcutaneous or subcutaneous interstitial sensor placements, depending on which code we're talking about. And so what this is this is a way to hook up a patient to a machine that will consistently give a readout of the glucose monitoring. So they tell us that 95249 and 95250 are used to report the service for subcutaneous interstitial sensory placement, hookup of the sensor to the transmitter, calibration of continuous glucose monitoring device, and patient training on the CGM device functions, and management, removal of the interstitial sensor, and the printout of captured data recordings. So again, very similar to things like the Holter monitors in cardiology, okay? So it includes putting it on the patient, having the patient take it home, removing it from the patient. This just goes a little bit more invasive. Now it goes on to tell us for the CGM device owned by the physician or other qualified healthcare professional's office, use 92520 for data capturing occurring over a minimum period of 72 hours. So again, instead of having the patient have to sit in observation or be an inpatient in the hospital, we can actually send them home to have this done, to find out what's going on with their blood glucose. So this could be done for a woman going through gestational diabetes, someone with type 1 diabetes, type 2 diabetes, secondary diabetes, or someone who is just having blood glucose levels and they just don't know what the problem is yet. Okay, now they tell us code 95249 may be reported only once during the time that the patient owns a given data receiver, including the initial episode of data collection. Code 95249 may not be reported for subsequent episodes of data collection unless the patient obtains a new and/or different model of data receiver. Obtaining a new sensor and/or transmitter without a change in receiver may not be reported with 95249. So if this is something that's going to go on for a lot longer than just a few days of testing, we cannot recode for these unless we're giving the patient a completely new device. So keep that in mind. Do not code 95249 unless we're giving them another new device. The other part is it may not be reported unless the patient brings the data receiver in to the physician's office or the qualified healthcare professional's office with the entire initial data collection procedure conducted in the physician or other qualified healthcare professional's office. So they have to come back in. Again, think Holter monitor. We hook up the patient, we send them home for a couple days, they come back, and we retrieve it. So keep that in mind. So again, this is minimum of 72 hours, or patient-provided equipment, or just the analysis, interpretation, and report. Again, watch out, this is more like a monthly code if someone's going to have this in a continuous basis. Now, when we get to the neurology and neuromuscular procedures, a lot of these, again, we're testing our nervous system. So we're testing the brain and we're testing the nerves in both the autonomic and peripheral and central nervous systems. So again, we always need to know what are we doing. So they tell us that the EEG, autonomic function, evoked potential, reflex tests, EMGs, NCVs, and MEG services include recording, interpretation, and report by a physician or other qualified healthcare professional. For interpretation only, use modifier 26. So again, in general, these codes include everything. Okay, they include taking the test, interpreting the test results, reading and writing the report. But again, if a technician is taking the test and the doctor is just reading and writing the report, we better put a modifier 26 for that provider. Now, some of these are based off of time. So again, they tell us recording time is when the recording is underway and the data is being collected. Recording time excludes setup and takedown time. So the second we actually start recording is when time starts, not when we hook the patient up to the machine. And it ends when we press the stop button and not when we're taking the recording equipment off the patient. So it's only the time it's physically testing the patient. And again, it's up to the provider or technician to tell us what to do. And for these tests, again, lots of different types of testing that we're going to see, again, that also deal with sleep medicine. Because again, a lot of times when people are going for sleep studies, we're also looking at the neurological procedures in their arms and legs. They actually get hooked up so that we can see if they might have something like restless leg syndrome. So they tell us, sleep medicine services include the procedure that evaluates adult and pediatric patients for a variety of sleep disorders. Sleep medicine testing services are diagnostic procedures using in-laboratory and portable technology to assess physiological data and therapy. All sleep services include recording, interpretation, and report. Okay, but if we're doing a report with modifier 52, if less than 6 hours of recording for 95800, 801, 806, 807, 810, 811, or if less than 7 hours for recordings of 95782, 95783, or if less than a 4-hour nap for 95805. So again, a lot of times people are always asking when to use 52. Well, we use 52 in a variety of circumstances, but the main time we use modifier 52 for reduced services is when the guidelines tell us to. So again, we want to make sure that we know time frames. And again, because it's going to be recording, we should have that information from the provider. Now, there's a lot of definitions. Again, biggest thing here, I'm not going to go through all of these. You should definitely read through them. And again, sometimes you might want to look up what it means, go a little bit more into detail about these definitions. The other thing I'd like to suggest, otherwise than obviously reading through these to understand, is when you get to these big pages where we have a whole bunch of definitions, like the cardiology ones with all the different monitoring services and sleep medicine testing and all those different monitoring services. The biggest thing, otherwise than reading through them, is you also may want to tab the page as information or definitions. You know, that is a great way of remembering that if you need more information, that's where you should go. Now, I know that some people are probably watching these to help with a class, which is great. I know other people are also watching this to prep for something like the CPC or other certification or credentialing exams. And for those certification or credentialing exams, most of them are multiple choice. And so when you're doing a multiple choice exam, if you have a question about what something means and you have it tabbed, you can just easily go there. And so again, just suggestions, remember, when it comes to certification and credentialing tests for coding and billing, anything physically written in your book is fair game, and any tabs or flags. So no sticky notes, but the ones that are smaller, they make them out of, plastic, paper, cardboard, things like that. I like the plastic ones. And usually, the CPT book will give you some of them, but they give you some extras. Feel free to use other ones as well. Whatever is going to help you get through understanding this information. And also, again, as you're learning about this, always go back and reread. Again, the more you become familiar with this, the easier it is, especially if, let's say, you're going for a job for coding for a sleep center. This is something that I would definitely want to look over before I went for that interview, so I had an understanding of what these were, and I might come up with a question or two to ask them, do they do these different types of testing, or do they only do a variety of them? So again, I will let you guys look through all of those. But here we go. So we finally get to some of the testing. So again, what are we doing? So we have, multiple sleep latency, our maintenance of wakefulness. We have a sleep study unattended. And again, for things like thoracoabdominal movement. So that is like a band that's going across the upper chest underneath where the breasts are for both men and women. And what that's doing, again, is making sure the patient is inflating and deflating their lungs as they're breathing. So again, what you need to keep in mind, we have attended, we have unattended. Now, most of the ones that you'll do at a sleep center are unattended, meaning that there's someone in the center, but they're not in the room with you. So we want to keep that in mind. There is a technician there, but they're not sitting in the room with you. For the home ones, which we'll see as well, we also want to keep in mind that, those are ones that the patient has to set up themselves. And again, what are we doing? How long? And specifically, what, piece of equipment did we give to the patient if they're doing it at home? So again, when it comes to pulmonology and sleep medicine testing, again, age definitions. For pulmonology, they like to do younger than 2. For sleep medicine testing, we have younger than 6 and older than 6. And again, you'll notice usually these are fully attended by a technologist. Why? Because if we are doing a sleep study on a young child, usually there's a very good reason. There are a couple of conditions out there where people stop breathing in the middle of the night, and it's not sleep apnea. It's not what we normally think of as sleep apnea. It's a condition where the nervous system does not tell the lungs to keep inflating and breathing. And so those can be very dangerous for children. There's also issues with the tonsils becoming enlarged, the adenoids becoming enlarged, the uvula becoming enlarged, and other possible issues. So again, keep in mind age is important here. Then we get to our routine EEGs. Now, when it comes to sleep studies, they're always going to put a couple little probes, usually right at the hairline of the patient. But these EEGs it's a cap, basically, and they're looking at as much as they can about the patient and their brain activity. So again, this is when we're doing different types of monitoring. So it lets us know that codes 95812 and 95822 includes hyperventilation and photic stimulation when appropriate. So again, they might ask the person to hyperventilate, to not have enough oxygen in their system, or to, again, do a photic stimulation, have them see something to see where the EEG ends up leading them to. Again, also goes on, routine EEG codes 95816 and 95822 include 20 to 40 minutes of recording. Extended EEG codes 95812 to 95813 include reporting times longer than 40 minutes. So again, time is important for these codes. You can see right here, 41 to 60 minutes, greater than 1 hour. Now, although we don't have any guidelines for muscle and range of motion testing, again, what specifically is the provider doing? And so again, we need to know, is it manual muscle testing? Are they doing a total body evaluation? Are they looking at the hands? Are they not looking at the hands? And again, this is range of motion. So we're dealing with people who have possibly had strokes, people who have different types of paralyses and pareses, also dealing with people that have sudden loss of muscle range of motion for unknown reasons. And then going along with a lot of the range of motion testing, we have what we call needle electromyography or EMG procedures. And again, what these do is they include the interpretation of electrical waveforms measured by equipment that produces both visual and audible components of electrical signals recorded from the muscles studied by the needle electrodes. And so this is exactly what it sounds like. They are actually sticking a needle electrode into not just a specific muscle, but a specific part of a muscle to see what's going on with that electricity. So for instance, if someone keeps saying, oh, the muscle in my lower left arm on the outer side, the lateral side, it keeps jumping all the time and I'm not doing anything. So they can look at that specific muscle and see what is happening with the nerve conduction. But again, where are we doing these? We need to be careful. Again, we can be doing extremities. We can also be dealing with paraspinal muscles, cervical paraspinal muscles, thoracic paraspinal muscles, lumbar paraspinal muscles, chest wall muscles, and abdominal wall muscles. We can also look for cranial nerve innervated muscles. Okay, so that's also going with the eyes as well. So again, we need to be careful. What are we doing and on what day? So again, we have codes for 1 extremity, 2 extremities, 3 extremities, 4 extremities, the larynx, the hemidiaphragm, the cranial nerves. So again, specifically, what are we doing? So right here, we can see the 3 extremities, 4 extremities, the larynx, the hemidiaphragm, the cranial nerves, unilateral cranial nerves, bilateral. So again, where are we doing this electroneedle myography? Okay, so we want to keep that in mind. Okay, I'm switching over to my other document, which picks up with, sorry about that, give me 1 second. It didn't jump over to nerve conduction tests. So again, these are going a little bit further. And one of the biggest things that we want to keep in mind with these is that now we're not looking for just one reaction. We're looking for the conduction. Where's the nerve go? Where, again, remember, we always have the nerve coming down from the central nervous system and either going out to the peripheral or the autonomic and then going back. And so we're looking at the pathways. Just like when we are looking at the ultrasounds of the vessels, we're looking at the pathways of blood. In this case, we're looking at the pathways of the nerve conduction, going down and back up. So, codes 95907 to 95913 describe nerve conduction tests when performed with individually placed stimulating recording and ground electrodes. The stimulating recording and ground electrode placement and the test design must be individualized to the patient's unique anatomy. Nerve tests must be limited to the specific nerves and conduction studies needed for a particular clinical question being investigated. So again, this is not something that we do just to see what's going on. There has to be a specific question, again, a differential diagnosis, possible diagnoses, or, again, a process of elimination diagnoses as well. The stimulated electrode must be placed directly over the nerve to be tested and stimulation parameters properly adjusted to avoid stimulating other nerves or nerve branches. And again, we're looking at one nerve and we're looking for, again, the conduction down and back from that nerve, that specific nerve. In most motor nerve conduction studies and in some sensory and mixed nerve conduction studies, both proximal and distal stimulation will be used. Again, going out and coming back. Motor nerve conduction study recordings must be made from electrodes placed directly over the motor point of the specific muscle to be tested. Again, specific. Sensory nerve conduction study recordings must be made from electrodes placed directly over the specific nerve to be tested. Waveforms must be reviewed on-site in real time, and the technique, meaning the stimulus site, recording site, ground site, or filter setting, must be adjusted as appropriate as the test proceeds in order to minimize artifact and minimize the chances of an unintended stimulation of adjacent nerves and the unattended recording from adjacent muscles or nerves. So again, very, very important. This means whoever is performing this test must be with the patient the whole time, because it's not just making sure we're getting that specific nerve conduction from the muscle. It's making sure that we are not getting any other nerve conductions. So again, this might include having to move the probe slightly, or again, to make sure that as we're doing the test, nothing is changing as the way the patient could be possibly physically moving by accident. And so again, this is going to be done by the examiner. So again, it goes on. Reports must be prepared on site by the examiner and consists of the work product of the interpretation of numerous test results using well-established techniques to assess the amplitude, latency, and configuration of each waveforms elicited by stimulation at each site of each nerve tested. This includes the calculation of nerve conduction velocities, sometimes including specialized F-wave indices, along with comparisons to normal values, summarizations of clinical and electrodiagnostic data, and physician or other qualified healthcare professional interpretation. Codes 95907 to 95913 describe one or more nerve conduction studies. For the purposes of coding, a single conduction study is defined as a sensory nerve conduction test, a motor nerve conduction test with or without an F-wave test. So again, each type of study, sensory motor with or without F-wave or H-reflex, for each nerve includes all orthodromic, antidromic impulses associated with that nerve and constitutes a distinct study when determining the number of studies in each groupings, like 1 to 2 or 3 to 4 nerve conduction studies. Okay, each type of nerve conduction study is counted only once when multiple sites in the same nerve are stimulated or recorded. Okay, and then it goes on. The number of these separate tests should be added to determine which code to use. For a list of nerves, see Appendix J, which is on page 794. Okay, so we have an entire appendix which helps us with these codes. So don't forget that that is going to be one of the easiest ways. And again, if it's still the same nerve but a different area on the same nerve, it's still one code. Okay, so it's how many nerves are we dealing with, not how many sites on the same nerve. And again, as it goes down, 1 to 2, 3 to 4, 5 to 6. And it continues to go on to 13 or more studies. Then we get to our intraoperative neurophysiology. Now, again, when we're talking about intraoperative procedures and intraoperative testing, again, these are usually for a very specific reason during a very specific procedure. And so what you need to know is what specifically is going on in the circumstance to make sure that you're coding for exactly what our provider is doing. So there are a lot of guidelines here, but there are only a couple of codes. So let's be careful that we know what is inside of them. Codes 95940 to 95941 describe ongoing neurophysiologic monitoring, testing, and data interpretation distinct from performance of specific tests and baseline neurophysiologic studies performed during surgical procedures. When the service is performed by the surgeon or anesthesiologist, the professional services are included in the surgeon or anesthesiologist primary service codes for the procedures and are not reported separately. So again, keep in mind what's going on in the circumstance. Do not report these codes for automated monitoring devices that do not require continuous attendance by a professional qualified to interpret the testing and monitoring. So again, this is someone physically there. As it goes on, this is what is included. Recording and testing are performed either personally or by a technologist who is physically present with the patient during the service. Supervision is performed either in the operating room or by real-time connection outside the operating room. So for instance, this could be someone next door or who's on the same floor but a couple of rooms next door doing this monitoring. The monitoring professional must be solely dedicated to the performance of the intraoperative neurophysiological monitoring and must be available to intervene at all times during the service as necessary for the reported time period. So again, they can't be doing other things. So it tells us for any given period of time spent providing these services, the services take full attention, and therefore other clinical activities beyond providing and interpreting of monitoring cannot be provided during the same period of time. It's kind of like critical care. Okay. When the provider or technologist is doing this, this is the only thing they can be doing. Okay. It goes on. Throughout the monitoring, there must be provisions for continuous and immediate communication directly with the operating room team in the surgical suite. Okay, so again, you know, this could be an intercom service, this could be a cell phone, this could be a variety of pieces of equipment. This could even be a live feed where they can talk back and forth through a Skype type service. Now, again, one or more simultaneous cases may be reported. So again, they could be looking at more than one person, but they can only be focusing on this data. And again, the biggest thing we need to keep in mind is what are we doing for this patient? It goes on to tell us that these codes 95940 to 95941 are reported based upon the time spent monitoring only, not the number of baseline tests performed or parameters monitored. So this is solely based on time. Okay, the time spent performing or interpreting the baseline neurophysiological study should not be counted as intraoperative monitoring, but represents separately reportable services, because again, that's looking at other paperwork. That is not intraoperative. When reporting 95940 and 95941, the same neurophysiological studies performed at baseline should be reported not more than once per operative session. And you'll notice these are add-on codes. They always are added on. Now again, time spent monitoring includes time to set up, record, and interpret the baseline studies and to remove electrodes at the end of the procedure. So again, only a time physically, monitored. Again, these are reported in 15-minute services. So again, we need to be careful. How much time are we dealing with? It goes on to tell us to determine units of service of 95940. Use the total minutes monitoring the operating room one-on-one. Monitoring may begin prior to incision. Report continuous intraoperative neurophysiological monitoring in the operating room in addition to the services related to monitoring from the outside of the operating room. So again, what are we doing? Are we physically there or not? So 95941 for all cases in which there was no physical presence by the monitoring professional in the operating room during the monitoring time or when the monitoring more than one case in the operating room. Okay, so again, we need to know 95940 is one-on-one monitoring requiring personal attendance. 95941 is monitoring from the outside operating room, remote or nearby from one or more case. So again, physically in the room or monitoring from a separate room. Okay, those are our choices. Again, we also have our autonomic function test. Again, we have to remember that, you know, the central nervous system and the peripheral nervous system are the two big systems. But the peripheral then separates out into the autonomic nervous system, which is what deals with the functions of all of our internal organs, including our heart, our lungs, our stomach, and every other internal organ we have, except for our brain, which is part of the central nervous system. Now, it goes on to tell us the purpose of autonomic nervous system function testing is to determine the presence of autonomic dysfunction, the site of autonomic dysfunction, and the various autonomic subsystems that may be disordered. Code 95921 should be reported only when electrocardiographic monitoring of heart rate derived from the time elapsing between two consecutive R waves in the electrocardiogram or at the RR interval is displayed on a monitor and stored for subsequent analysis of waveforms. So again, what they're telling us is what we're really looking at here is when we're looking at the autonomic function test, specifically for code 95921, which deals specifically with saying cardiovagal innervation. So going to the heart. Again, we're going from R to R. So remember, we have the PQRS and T waves. So again, we're looking from R to R when it comes to the heart rate. Now they go on, a tilt table may be used, but is not required equipment for testing of parasympathetic functions. So again, that's when they're literally tilting the patient up and down to see what happens when they move the body. If the autonomic functions, the autonomic nervous system functions properly. Now, at least 2 of the following components need to be included in this testing. Okay, so we're looking at things like the heart rate responsive to deep breathing with the visual quantitative analysis of recording for a rate of 5 to 6 breaths per minute. And then we also have the Valsalva ratio determined by dividing the maximum heart rate by the lowest heart rate. So the Valsalva pressure is really looking at what happens with what we call cardio acceleration. We're looking at tachycardia, bradycardia, things like that. A 30-15 ratio, which is the R to R interval, again, to see what is possibly going on. And then we also have performance of a passive head up tilt with continuous recording of beat-to-beat blood pressures. So again, we have to be hitting at least 2, to be able to code for these. Now, 95922, as it goes on to tell us, is reported only when all 4 of the components are there. So again, what specifically are we looking at? Then we get to the special EEG testing. So these are ones that are going to be usually quite a bit longer than what we're used to. Okay, so we're going to see things like codes 95950 to 95953 and 95956 are used per 24 hours of recording. For recording more than 12 hours, do not use modifier 52. For recording of 12 hours or less, use modifier 52. So as long as we hit 12 out of the 24 hours for that code, we can use it. If we use 11 hours, 10 hours, 5 hours, then we use modifier 52 for reduced services. Okay, and so that's one of the big things we want to keep in mind. So there's only a couple of these monitorings, but we want to know specifically what are we dealing with. Now, when we look at nervous system surgery, we look at the insertion of a neurostimulator. Now, just like we've looked at for our cardiac devices, like our ICDs and pacemakers, we've looked at the cochlear device, the analysis, programming, and reprogramming of a device that we place in the body is always going to be found in medicine. So again, what are we doing to the device? Okay, are we doing an analysis? Are we doing a programming? Are we doing a reprogramming? Are we doing an intraoperative analysis? So that's what we need to be careful. What specifically is our provider doing with this device? Again, this is not the placement. This is not the initial placement. This is the analysis and programming of it. So it tells us, simple intraoperative or subsequent programming of neurostimulator, pulse generator, or transmitter, 95971, includes change to 3 or fewer of the following parameters: rate, pulse amplitude, pulse duration, pulse frequency, 8 or more electrode contacts, cycling stimulation for train duration, train spacing, number of programs, number of channels, alternating electrode polarities, dose time, which is the stimulation parameters changing in time periods of minutes, including dose lockout times, and more than one clinical feature, like rigidity, dyskinesia, or tremor. Okay, so we're looking at 3 or fewer of those if it's simple intraoperative or subsequent programming. Complex intraoperative or subsequent programming includes changes to more than 3 of above. So again, simple versus complex. Now, some more specifics on a couple of these specific codes. Code 95970 describes a subsequent electronic analysis of previously implanted simple or complex brain, spinal cord, or peripheral neurostimulator pulse generator systems without reprogramming. Code 95971 describes intraoperative or subsequent electronic analysis of an implanted simple spinal cord or peripheral neurostimulator pulse generator with programming. Code 95972 describes intraoperative or subsequent electronic analysis for implanted complex spinal cord or peripheral neurostimulators. So again, and it goes on to tell us that, again, we need to know, is this something that's going to be simple or is it going to be complex? So 95974 and 75 describe the intraoperative or subsequent analysis complex cranial. 95978 and 79 are talking about the initial or subsequent electronic analysis of the implanted brain neurostimulator. So again, when are we doing these analyses? And then it goes on to tell us codes 95980 describes an intraoperative electronic analysis of an implanted gastric neurostimulator or pulse generator. So again, where is the neurostimulator? They can be in many different parts of the body. Now, one of the neat set of codes that we have is this motion analysis. So if you ever watched how like computer generated movies are made, 3D computer generated movies are made, and even if you go back into some of the late 90s Disney movies, you'll see they use motion analysis to figure out how somebody moves. And so we've had this technology for a while, and we've been able to use it for quite some time, since about 2002, to help people with what's going on with their walking and their movement. And so basically what we can do is we have different types of sensors that we can attach to part of the body. Usually they're attached to a couple different points in the arm, a couple different points in the leg, and usually around the hips. And what we can do is we can have the person actually walk through a very specific area that there will be motion capture by using those probes that they've put on their body. Usually they're like little Velcro areas. And what we're able to do is we're able to figure out what's wrong. Is it a gait problem, meaning with walking? Is it an area where they're not standing all the way upright? Or do they have a hunch or something like that? And so we have a couple different ways that we can look at these, but all using different types of really interesting pieces of equipment. So they tell us codes 96000 to 96004 describe services performed as part of making therapeutic or diagnostic decision-making process. Motion analysis is performed in a dedicated motion analysis laboratory, like a facility capable of performing videotaping from the front, back, and both sides, computerized 3D kinematics, 3D kinetics, and dynamic electromyography. Code 96000 may include 3D kinetics and stride characteristics. Code 96002 and 96003 describe dynamic electromyography. Code 96004 should be reported only once, regardless of the number of studies reviewed or interpreted. And as I was reading that, I thought of another one that's much more recent. If you see any of the recent movies with the Hulk in it, the gentleman actor who does the voice of the Hulk, he doesn't just do the voice. What they do actually is they put him in a specialized suit that has, again, these points on it that a computer can pick up. And while he's saying lines, he's actually physically acting out the lines as well in front of these computers. And they do a motion analysis so that when they create the Hulk in the computer generated side, they can mimic the motions and actions of the actual actor. And again, we can do a version of this on the medical side to see what could be going on with either the gait, the walking of the patient, or with the structure of how they're walking and how they're positioning either the lower half or the upper half of their body. Very neat codes. No, functional brain mapping, again, this is dealing with looking at the different parts of the brain. So they tell us that code 96020 includes selection and administration of testing of language, memory, cognition, movement, and sensation, and other neurological functions when conducted in association with functional neuroimaging monitoring of performance of this test and determination of validity and neurofunctional testing relative to specific interpretive functional magnetic resonance imaging. So see down here, you'll use this, the fMRI is 70555. Okay, so what this is, fMRI is functional magnetic resonance imaging. What they show is they show the way the brain reacts to different stimuli. So the neurofunctional testing itself of the brain mapping, what they're doing is while the patient's in the MRI machine, they are showing them pictures that are usually right above them so they can look at them, and they're to evoke different emotions. So again, they might show a puppy, and that might make the person happy, so we can see where happiness and pleasure comes from. If we know the person is terrified of spiders, they might then show the person a picture of a couple of tarantulas, and then we can see where the fear is in the brain. And so this goes with the functional MRI testing to get a better understanding of what's going on in the person's brain, and does their neurofunctional testing match people of the approximate age and gender that they are, or is there something different about it? Our next little section is the medical genetics and genetic counseling services. So again, there's one code for these services. And as they say, these services are provided by a trained genetic counselor and may include obtaining a structured family genetic history, pedigree construction, analysis for genetic risk assessment, and counseling of the patient and family. These activities may be provided during one or more sessions and may include review of medical data and family information, face-to-face interviews, and counseling services. Okay, so genetic counseling. Genetic counselors are a very specific type of counselor. They do have to be licensed. It is a graduate program, so they have to get a bachelor's and then go back to do genetic counseling. And this is to look for very specific genetic problems that we either already know about or we might suspect. We also can do this after a baby's been born and we find out that there might be something wrong with their genetics. So, for instance, when we have a couple of disorders that are genetically linked that we absolutely can tell, the genetic link between them, and as long as we test mom and dad, the genetic counselor can give them the probability, which is the analysis for genetic risk assessment of having a baby with that condition. For instance, Tay-Sachs. Tay-Sachs runs in very specific genetic lines, and if mom and dad are both from that Mediterranean area around the Mediterranean Sea, then they might want to get tested to see what the probability of them having a child with Tay-Sachs. The same thing with sickle cell anemia. We're also going to see it with other genetic disorders that are known and some that are unknown. And again, sometimes we do this after a baby is born, and then they say, well, we think it's definitely something genetic, so let's look into it. Now, again, these are each 30 minutes, and so we want to make sure that we code for how much time they spend face-to-face with the patient. Now, in part one of this, we talked about psychotherapy, and I said that there were going to be some tests that we are going to end up looking at that are towards the end of medicine, and these are those tests. So these are central nervous system assessments and tests, which include neurocognitive, mental status, and speech testing. So again, as it tells us, the following codes are used to report services provided during the testing of cognitive function of the central nervous system. Cognitive processes, visual motor responses, and abstract abilities is accomplished by the combination of several types of testing procedures. It is expected that the administration of these tests will generate material that will be formulated into a report. Now, for these specific codes, a minimum of 31 minutes must be provided to report any hour code. And then they tell us services 96101, 96116, 118, and 125. Report time is face-to-face with the patient and time spent interpreting and preparing the report. So again, time is important here. So we're looking at these codes. Again, what specifically are we doing? So for instance, if we have a young child who has consistently not met the expected timeframes for development, we might do something like 96111, developmental testing, including assessment of motor language, social, adaptive, and/or cognition functioning by standardized developmental instruments with interpretation and report. Versus if we had someone that perhaps had a stroke and is now having dysphagia, we have assessment, or aphasia, I should say, assessment for aphasia, including assessment of expressive and receptive speech and language function, language comprehension, speech production ability, reading, spelling, writing, things like by the Boston Diagnostic Aphasia Examination, with interpretation and report per hour. So again, we have codes that they have very specific criteria that they go over for these. We even have things like different types of psychological testing. So for instance, 96103, psychological testing includes psychodiagnostic assessment of emotionality, intellectual abilities, personality, and psychopathology. They use things like the MMPI, which is a very specific set of questions. And again, for these, they can be used for a variety of circumstances. They could be for people, children who are not meeting developmental milestones, people that have had accidents and injuries, strokes, things like that. But we can also use these codes, and a lot of times companies where people are applying for very high positions or certain governmental positions will be required to get this testing done. For instance, if someone wants to work for the FBI or the CIA, they're going to have to go through some of the psychological testing, because in those types of circumstances, you can't tell anyone information. And so they need to make sure that this person is capable of not giving that information. So they will send them to a psychologist who will perform this type of testing on them, prepare a written report, and send it back. And this is when you might see some of those modifier 32s for the mandated services for a job. Now, the next set of codes that we're going to see is for health and behavioral assessment and intervention. Now, we've seen codes similar to these in E&M. But these are going to be, for psychophysiology and things like that. So it tells us health and behavioral assessment procedures are used to identify the psychological, behavioral, emotional, cognitive, and social factors important to the prevention, treatment, or management of physical health problems. The focus of the assessment is not on mental health, but on the biopsychosocial factors important to physical health problems and treatments. The focus of the intervention is to improve the patient's health and well-being, utilizing cognitive, behavioral, social, and/or psychophysiological procedures designated to ameliorate specific disease-related problems. Codes 96150 to 96155 describe services offered to patients who present primarily physical illnesses, diagnoses, or symptoms, and may benefit from assessments and interventions that focus on the biopsychosocial factors related to the patient's health status. These services do not represent preventive medicine counseling and risk factor reduction intervention. So again, these are different from the E&M. Now, for patients that require psychiatric services as well as health and behavioral assessment interventions, report the predominant services performed. So we do not report 96150 and 96155 with the 90785 and 90899 on the same date. Okay, so again, we also do not report 99401 to 99402 on the same date. So we also want to keep that in mind. So this is maybe for someone who has fibromyalgia and is having depression with physical symptoms. We want to try to figure out how to create a better environment for that person's body and their general health and well-being. Then we get back to what we kind of started with way a long time ago when we were looking at the immunoglobulins, which is the hydration, therapeutic, prophylactic, diagnostic injections, and infusions, and chemotherapy, and other highly complex drugs or highly complex biological agent administration. So the first thing I want to tell you before we even get into this is I've known a couple of coders who have done infusion services and chemotherapy and stuff like that. And what they do usually is they create their own cheat sheet of these codes that helps them code when they get these services back. Because as we're going to look through, there's different hierarchies that they use to describe which drugs and when we're putting them in. But we're also going to use these codes for if someone just needs IV hydration, or if someone needs an injection or any type of intravenous or intraarterial drug that's not chemotherapy as well. Now they tell us, physician or other qualified healthcare professional work related to hydration, injection, and infusion services predominantly involves affirmation of treatment plan and direct supervision of staff. So usually these are nurses, possibly physician assistants who are really dealing with the patients, but there's always supervision of a qualified healthcare professional. Okay, now again, these codes 96360 to 96379, 96401, 402, 409 to 425, and 521 to 523 are not intended to be reported by the physician in the facility setting. These codes are for the facility to code for. Okay, so the physician gets to code for the oversight services for them or an E&M service when they meet with the patient, but they cannot code for this because, again, it's not being done by the physician, it's being done by the nursing staff. Now, if performed to facilitate the infusion or injection, the following services are included and not reported separately. So the use of local anesthesia to numb the area, the IV start Access to an indwelling IV subcutaneous catheter port. Again, those are usually placed well beforehand. Again, PICC lines and ports. Flush at the continue of the infusion to make sure the entire drug's gotten into the system, and all standard tubing, syringes, and supplies. Okay, so again, the one thing that is not included is what is inside that, syringe or that IV. That's going to be separate. Okay, now, when multiple drugs are administered, report the services and the specific materials or drugs for each. So that's where HCPCS is going to come in with the drugs themselves. Now, we have initial services, we also have subsequential services, and we have concurrent infusions, and we're going to go through what each and every one of those means, okay? So when administering multiple infusions, injections, or combinations, only one initial service code should be reported for a given date unless protocol requires that 2 separate IV sites must be used. And again, that is uncommon, okay, but it does happen. So it's kind of like if the patient is being admitted to the hospital or nursing home, we only use the initial hospital or nursing care code once, and then we can use the subsequent. Same thing here, only one initial service code unless we have 2 separate IV sites. Now, do not report a second initial service on the same date due to an intravenous line requiring a restart, an IV rate not being able to be reached without 2 lines, or for accessing a port of a multi-lumen catheter. So again, if something happens, if the catheter, something goes wrong or this and that, and they have to put in a separate one, that is not this. So we need to be careful, okay, what's going on with the patient. It goes on to tell us, if an injection or infusion is of a subsequent or concurrent nature, even if it's first such service within the group of services, then a subsequent or concurrent code from the appropriate section should be reported. Example, the first IV push given subsequent to an initial 1-hour infusion is reported using a subsequent IV push code. So again, only one initial code per session unless they have to use 2 separate IVs. And again, that's very uncommon. So they tell us the initial infusion is the key or primary reason for the encounter, reported irrespective of the temporal order in which the infusion or injections are being administered. Okay, so again, what's the primary reason for the encounter? What's the main drug we're giving them? For facility reporting, initial infusion is based using the hierarchy. For both physician and other qualified healthcare professionals, and facility reporting, only one initial service code should be reported unless the protocol or patient condition requires that 2 separate IV sites must be utilized. Yet again, that's uncommon. In the difference in time and effort in providing the second IV site access, it is also reported using the initial service code with modifier 59. Why? Because we need to tell the insurance company this was separate, and then we're going to have to connect it with the diagnosis code that explains why we needed 2 separate IV sites. Now again, the subsequent or sequential infusion. Sequential infusion is an infusion or IV push of a new substance or drug following a primary or initial service. All sequential services require that there be a new substance or drug, except that facilities may report a subsequential intravenous push of the same drug using 96376. And again, so the infusion is the bag, and there's a time frame that goes with it. An IV push is exactly what it sounds like. We take a needle that has a very specific drug in it, we attach it to the same IV the patient already has, and we inject it, okay? So again, we need to be careful. What drugs are we using? What do they document? For concurrent infusions, concurrent infusion is an infusion of a new substance or drug infused at the same time of another substance or drug. A concurrent infusion service is not time-based and is only reported once per day, regardless of whether an additional new drug or substance is being admitted concurrently. So again, they're happening at the same time. Now, hydration may not be reported concurrently with any other service. A separate subsequent concurrent administration of another new drug or substance, the third substance or drug, is not reported. So again, hydration is included, like it said originally. Now again, I put hierarchies by facilities here, In order to determine which service should be reported as the initial service when there's more than one type of service, hierarchies have been created. These vary by whether the physician or other qualified healthcare professional or the facility is reporting. The selection for reporting is based on the physician or other qualified healthcare professional's knowledge of the clinical condition and treatment. The hierarchy that facilities are to use is based upon a structural algorithm. Okay, so they are given information and said, this is the hierarchy that you can use. Okay? When these codes are reported by the physician or other qualified healthcare professional, the initial code that best describes the key or primary reason for the encounter should always be reported irrespective of the order for which the infusions or injections occur. So remember, when it comes to sequencing, what's the main reason for the patient's encounter? Okay, that's the code that's going to be our initial code. But when these codes are reported by the facility, the following instructions apply. The initial code should be selected using a hierarchy whereby chemotherapy services are primary to therapeutic, prophylactic, and diagnostic services, which are primary to hydration services, which makes sense because chemotherapy is much more damaging to the body than other types of therapies and hydration. This hierarchy is to be followed by facilities and supersedes parenthetical instructions for add-on codes that suggest an add-on of a higher hierarchical position may be reported in conjunction with a base code of a lower position. For example, the hierarchy would not permit reporting 96376 with 96360, as 96376 is a higher order code. IV push is primary to hydration. So again, the facility will have their own hierarchies, and we also have to follow what it says in the book. When reporting multiple infusions of the same drug or substance on the same date of service, the initial code should be selected. The second and subsequent infusions should be reported based on the individual times of each additional infusions of the same drug or substance using the appropriate add-on code. So let's look at this example. So again, in the outpatient observation setting, a patient receives 1-hour intravenous infusions of the same antibiotic every 8 hours on the same date of service through the same IV access. The hierarchy for facility reporting permits the reporting of codes 96365 for the first 1-hour dose administered, and add-on code 96366 will be reported twice, once for the second and the third hour of infusions of the same drug. Okay, so again, we need to be careful on timing. Goes on. When reporting codes for which infusion time is a factor, use the actual time over which the infusion is administered. So, an intravenous or intraarterial push is defined as A, an injection in which the individual who administers the drug or substance is continuously present to administer the injection and observe the patient, or B, an infusion of 15 minutes or less. So again, it's one or the other for an IV or IA push. Okay. Now let's look at hydration specifically. Codes 96360 to 96361 are intended to report a hydration IV infusion to consist of prepackaged fluid and electrolytes like normal saline, D5-1/2 normal saline with 30 ml equivalents, but are not used to report infusion of drugs or other substances. Hydration IV infusions typically require direct supervision for purposes of consent, safety oversight, or inter-service supervision of staff. Typically, such infusions require little special handling to prepare or dispose of, and staff that administer these do not typically require advanced practice training, because again, this is just establishing the IV and hooking them up to hydration, hooking them up to an IV bag, which is basically just water, a little bit of salt, and electrolytes. Now, what we have to be careful is some chemotherapeutic agents and other therapeutic agents require pre and or post hydration to be given in order to avoid specific toxicities. A minimum duration of 31 minutes of hydration infusion is required to report these services. However, the hydration codes 96360 and 96361 are not used when the purpose of the intravenous fluid is to, quote, keep open an IV line prior or subsequent to a therapeutic infusion, or as a free-flowing IV during chemotherapy or other therapeutic interventions. Okay, so let's go back. So here's the thing. In general, if we're giving hydration to a patient during chemotherapy, okay, it's included. But if we are giving people hydration before and after chemotherapy and we hit 31 minutes, then we can use these codes, okay? But if we are, let's say, again, there are so many different drugs out there for so many different reasons. So let's say chemotherapy, okay? A patient comes in, they get drug A for 2 hours. Then for 20 minutes, they get just the hydration, and then we jump into drug number 2 after that, okay, drug B. That 20 minutes does not meet the definition of 96360. We cannot code for it. If they hit 45 minutes, that's a little different, okay? So again, we have to be careful. Timing as well as situation is important. Hydration is really just used for when this is the only thing we are doing for the patient. So again, as we go into spring and summer, there's day-long events, there's going to be carnivals, there's going to be people going to the beach, there's going to be parties, there's going to be a day-long concert. This is when we're going to start seeing these issues. People get dehydrated, they need hydration therapy. Where we need to be careful is when people are getting another drug or chemotherapy and hydration at the same time. Again, same time hydration is included. If it's at separate times, we need to hit 31 minutes. Now, when it comes to the rest of these, what we need to know is what are we giving the patient? Because again, we have chemotherapy and non-chemotherapy drugs. So again, for instance, years ago, Boniva, which is for bone density to help against osteopenia and osteoporosis, okay? It used to be a once a day, then it went to a once a week, then it went to a once a month pill. But then they came out with a once a year infusion. Okay, so that's where these things are going to come in, okay, because these codes coming up are not chemotherapy or other highly complex drugs. Again, we also use things like interferon, which is a drug that we use for different inflammatory disorders. We use it for things like Crohn's disease. And again, people will come in to get an intravenous infusion of them every couple of months, okay? So we need to keep that in mind. This also can be used for blood products as well. If someone's going to be hooked up to an IV of blood product, for instance, someone that's missing factor 12 from their body might get an IV infusion once a month of factor 12 into their system. So they tell us, a therapeutic, prophylactic, or diagnostic IV infusion or injection other than hydration is for the administration of a substance or drug. When fluids are used to administer the drug, the administration of fluid is considered incidental hydration and is not separately reported. Again, if all we're doing is hydration and we hit 31 minutes, we can code it. If we are doing other infusions and we have to be using hydration, it's included. Okay. These services typically require direct supervision for any or for all purposes of patient assessment, provision of consent, safety oversight, inter-service supervision of staff. Typically, such infusions require special consideration to prepare, dose, or dispose of, require practice and competency for all staff who administer the infusions, and require periodic patient assessments with vital sign monitoring during the infusion. These codes are not intended to be reported by the physician or other qualified healthcare professional in the facility settings. Again, these are for the facility because these are nurses usually or physician assistants who have been specifically trained in giving these types of therapeutic infusions. Again, hydration is something that anyone who knows how to do an IV start line can give a patient. Okay, but when it comes to some of these highly complex drugs and these other biologicals, you have to be properly trained to do infusions. Now we have another set for chemotherapy, which comes after these codes. Okay, so again, we need to know what we're doing. Are we dealing with a drug, or are we dealing with chemotherapy or something that's highly complex? Now, whether or not it's highly complex, that's something that you're going to have to do a little bit of investigation into. And usually they would tell you that this is something that is highly complex. So chemotherapy administration codes, which are 96401 to 96549, apply to parenteral administration of non-radionucleotide antineoplastic drugs and also to antineoplastic agents provided for treatment of non-cancer diagnoses. So we have things like cyclophosphamide for autoimmune conditions. Okay, so again, these are for chemotherapy and other highly complex drugs. Again, these services can be provided by any physician or other qualified healthcare professional. It then goes on to tell us that chemotherapy services are typically highly complex, require direct supervision for any and all purposes of patient assessment, provision of consent, safety oversight, and intra-site services. Again, these people have to have special training. So this is talking about all the special training you have to be able to do this. Now, when performed to facilitate the infusion of injections and preparations for chemotherapeutic agents and highly complex agents or other highly complex drugs, is included and not reported separately. So again, we need to be careful. We need to know which infusions are not this level of complexity. So again, what are we giving the patient? It goes on to tell us, report separate codes for each parenteral method of administration employed when chemotherapy is administered by different techniques. So again, there's all different ways that we can get chemotherapy into the body. How are we doing it? Now, the administrations of medications such as antibiotics, steroidal agents, antiemetics, narcotics, and analgesics administered independently or sequentially as supportive management of chemotherapy should be separately reported. So again, while someone's getting chemotherapy, they're also going to be getting an IV drip of a narcotic to help them with pain. Then again, that's not a highly complex drug. We go back to the regular infusions that we were just looking at. Now, this is important. Regional isolation chemotherapy perfusion should be reported using the codes for arterial infusion 96420 to 96425. Placement of the intraarterial catheter should be reported using the appropriate code from the cardiovascular section. Okay, and they're also telling us placement of an arterial and venous cannula for extracorporeal circulation via membrane oxygenator perfusion pump should be reported using 36823. So again, what other equipment are we using while we're doing this for the patient? That is important for us to know. All right, now we have some new and revised codes for photodynamic therapy this year. They tell us codes 96573 and 96574 should be used to report non-surgical treatment of cutaneous lesions using photodynamic therapy by external application of light to destroy pre-malignant lesions of the skin and adjacent mucosa, like on the face or scalp, by activation of photosensitizing drugs. Okay, now you see how down here we do not report codes for debridement, lesion shaving, biopsy, or lesion excision. That's because most of the times when we think of pre-malignant lesions, we think of the destruction procedures that happen towards the end of the integumentary surgery. This is not those. Those are using things like hot and cold lasers, using cryotherapy, stuff like that. What they do is they put a photosensitizing drug on the area. Then they use a very specific application of light that actually will destroy that lesion, okay? So basically, the photosensitizing drug reacts to the type of light and destroys the lesion, okay? So again, this is not lasers, this is not cryotherapy, that's why these codes are different. Now, it goes on to tell us that a treatment session is defined as an application of a photosensitizer to all lesions within an anatomic area. That's also what's a little different. With or without debridement of all premalignant hyperkeratotic lesions in that area, allowed by illumination and activation with appropriate light sources to the same area. So again, we're using light sources and photodynamic drugs, not hot and cold and lasers and things like that, which is what makes them very different from what we see. Okay, so again, what we need to kind of keep in mind here is when we're doing these procedures, exactly what are we doing? Now, the next section then goes on for the special dermatological procedures, but those guidelines don't show up till page 684. So this is the top page 684. And it tells us for these procedures, 96931, 32, 33, 34, 35, and 36, describe the acquisition and or diagnostic interpretation of the device-generated stitched image mosaics related to a single lesion. Do not report 96931, 32, 33, 34, 35, or 36 for a reflected confocal microscopy examination that does not produce mosaic images. Okay. For services rendered using reflectant confocal microscopy, not generating mosaic images, use 96999, which is one of our unlisted codes, which yet again may not get paid for. So again, we have to be careful what is and what is not included in some of these special procedures. Then we get to our physical medicine or rehabilitation. So a few years ago, actually it was, I should say not a few years ago, it was last year, 2017, we saw some new updates to these codes. So these codes used to look more like the other traditional medicine codes, where it was just what are we doing for the patient. They then updated these codes to have some key components like we have in E&M, but they're different from E&M because of the nature of these. So as we read through the definitions and guidelines, what we want to be careful for is exactly what are we doing? Are we doing physical therapy? Are we doing occupational therapy? Are we doing athletic training? Or are we using a modality to actually give this? So what are we doing for the patient? So the first thing is codes 97010, 97763 should not be used to report each distinct, should be used to report each distinct procedure performed. Do not append modifier 51. We get paid at 100% for each of these procedures that we do. Now, the work of the physician or other qualified healthcare professional consists of face-to-face time with the patient and caregiver, if applicable, delivering skilled services for the purposes of determining the total time of service. Incremental intervals of treatment at the same visit may be accumulated, meaning they're going to see what the patient needs, how often they should come, and what they're going to do for them. Now, for the physical therapy evaluations, again, this is what's included. So it includes a patient history and examination with development of a plan of care conducted by the physician or other qualified healthcare professional, which is based on the composite of the patient's presentation. Again, all very specific to the reason for the encounter. Coordination, consultation, and collaboration of care with physicians, other qualified healthcare professionals, or agencies is provided consistent with the nature of the problems and the needs of the patient, family, and/or other caregivers. At minimum, each of the following components noted in the code descriptors must be documented in order to report the selected level of physical therapy evaluation. Physical therapy evaluation include the components as follows: history, examination, clinical decision-making, and development of a plan of care. So very similar to E&M. Okay, they're still doing history, they're still doing exam, they're doing their own decision-making, clinical decision-making, but they're also doing a development of a plan of care. What's going to happen next? What modalities are they going to use? And how often? Okay, so what we have here is we have kind of like the initial, and then we have the re-evaluation. So we have the evaluation and the re-evaluation. Okay, now we have some definitions that are important here. So the level of the physical therapy evaluation performed is dependent on the clinical decision-making and the nature of the patient's condition or severity. For the purposes of reporting physical therapy evaluation, the body regions and the body systems are defined as follows. Body regions are head, neck, base, lower extremities, upper extremities, and trunk. Body systems are musculoskeletal, neuromuscular, cardiovascular, pulmonary, and integumentary. A review of body system includes, for musculoskeletal system, assessment of gross symmetry, gross range of motion, gross strength, height, and weight. For neuromuscular, general assessment of gross coordinated movement, balance, gait, locomotion, transfers, and transitions, and motor function, motor control, and motor learning. For cardiovascular pulmonary system, the assessment of heart rate, respiratory rate, blood pressure, and edema. And then it goes on for the integumentary system, the assessment of pliable or texture, presence of scar formation, skin color, and skin integrity. It goes on to tell us, though, a review of any body system also includes the assessment of the ability to make needs known, consciousness, orientation, person, place, and time, expected emotional and behavioral response, and learning preferences, like learning barriers and educational needs. Again, it depends on how old the person is and what needs they might have. Now, the body structures, the structural or anatomic parts of the body, such as organs, limbs, and their components, are classified to body systems. So again, when they use body structures, we're really using body systems. Now, personal factors, these factors that include sex, age, coping styles, social background, education, profession, past and current experiences, overall pattern, behavioral pattern, character, and other factors that influence how disability is experienced by the individual. Personal factors that exist but do not impact physical therapy plan of care are not to be considered when selecting a level of service. So for instance, if we have someone that, let's say, got a repetitive injury on their right thumb, they're going to be treated very differently than someone that got a C5 fracture injury to their neck and is now a paraplegic. Okay, so again, this is all going to be very individual. So what we see is we have low complexity, moderate complexity, high complexity, and reevaluation. Okay, so here's the low complexity. Okay, so we need to keep that in mind. Then we get to our occupational therapy evaluation. So again, we need to be careful. Is this physical therapy? Is this occupational therapy? So occupational therapy evaluation includes an occupational profile, medical and therapy history, relevant assessments, and development of a plan of care, which reflects the therapist's clinical reasoning interpretation of data. Coordination, consultation, collaboration of care with physicians or other qualified healthcare professionals or agencies is provided consistent with the nature of the problem and the need for the patient, family, and or caregiver. And again, it goes on to tell us, at minimum, each of the following components noted in the code descriptors must be documented in order to report the selected level of occupational therapy. So these are things they have to document. Again, the occupational profile and client history, assessment of occupational performance, clinical decision-making, development of a plan of care. Okay, so again, this is for occupational issues. So again, people getting hurt on the job, workers' comp, things like that. The level of occupational therapy evaluation performed is determined by patient condition, complexity of clinical decision-making, and the scope and nature of the patient's performance deficits relating to physical, cognitive, or psychosocial skills to be assessed. The patient's plan of treatment should reflect this assessment at each of the identified performance deficits. So a performance deficit is referred to an inability to complete activities due to lack of skill in one or more of the categories below. Again, so physical skill refers to the impairments of body structure or body functions. So again, balance, mobility, strength, endurance, fine or gross motor coordination, sensation, and dexterity. Cognitive skills refer to the ability to attend, perceive, think, understand, problem solve, mentally sequence, learn, and remember, resulting in the ability to organize occupational performances in a timely and safe manner. These skills are observed when 1, a person attends to and selects, interacts with, and uses task tools and materials. 2, carries out individual actions and steps. And 3, modifies performance when problems are encountered. And then we've got the psychosocial skills, which refer to interpersonal interactions, habits, routines, and behaviors, active use of coping strategies, and or environmental adaptations to develop skills necessary for successfully and appropriately participate in everyday tasks and social situations. So these can also be used for people that are having issues getting into a particular field or want to figure out what they are capable of doing. So again, we still have a low, a medium, a high, and then a reevaluation. We then have the athletic training, which is exactly what it sounds like. This also includes a patient history and examination with development of a care plan conducted by the physician or other qualified healthcare professionals. There's no coordination and consultation and collaboration of care, but again, a little bit similar, but yet different. The athletic training evaluations must include the following components: history and physical activity profile, examination, clinical decision-making, and development of plan of care. Again, for the definitions, we are using ones that are similar to our physical therapy. Again, the same body areas, the same body systems, the same information. For the body systems, these are all the same that we've already looked at and read through. Again, we have low, we have medium, we have high complexity, and then we have reevaluation. So again, that's just to try to figure out what we're going to do next. Then we get to our modalities. Modalities are the codes that we use for the actual different types of therapeutic procedures that we're doing. Some of them are supervised, meaning that the provider's there the whole time. Some of them are non-supervised. So they tell us any physical agent applied to produce therapeutic changes to biological tissue includes but is not limited to Thermal, acoustic, light, mechanical, or electric energy. So thermal, hot and cold, acoustic, using sound, of course, light, mechanical, which can produce electrical movements, and the electrical energy itself. So again, we have everything from hot and cold packs to different types of traction, electrical stimulation. This is really interesting. It's like a little, it looks like a Holter monitor. And what they do is they put these probes, just like they do for an EKG or a Holter monitor, around the area of muscle or tendons that has a problem. And what they do is they set the little mechanism, and it will send an electrical impulse into that area. And it's dependent on the reason of how often they send that signal in. They can adjust it. And again, this is something where they can kind of let the muscles get the electrical stimulation of movement and then see what's happening afterwards. We have everything from paraffin baths to ultraviolet light to infrared, you name it. So those are supervised, again. Then we have constant attendant. Again, this is direct one-on-one. So this is electrical stimulation here. We have contrast baths, ultrasound, the Hubbard tank. So again, these are things that people are going to be specifically there with the patient the entire time. There's also a couple of therapeutic procedures as well. And again, this is manner and affecting change, so the application of clinical skills and or services that attempt to improve functions. So again, therapeutic exercises for strength, endurance, range of motion, flexibility. Again, neuromuscular re-education, that could be after like a fracture, aquatic therapy, which can be very helpful to a lot of people, gait training and stair training, again, maybe someone that's had a stroke, massage. So again, lots of different things that we can do. What we need to know is specifically, what are we doing for the patient, okay? Are we doing the visit, or are we doing the modalities? Okay, ooh, I just want to show you guys, we even have things like wheelchair management and work hardening and conditioning. So again, to see what the patient can do, what they can't do. The next set of codes is active wound care management. Again, the guidelines have been revised a little bit and tells us, again, active wound care procedures are performed to remove devitalized and or necrotic tissue and promote healing, chemical cauterization to achieve wound hemostasis, and is included in the wound care procedures and should not be separately reported for the same lesion. Services require direct one-on-one contact with the patient. So we do not use code 17250. It is included in these wound care procedures. Again, the reason is because we always need to get the fresh skin when we're doing active wound care management. We don't want dead skin, we don't want decaying skin, we don't want infected skin, and so they have now decided to include this in these wound care procedures. And again, what exact type of wound care are we doing for the patient? Although we don't have any guidelines, we do have some revised information for the orthotic management training, prosthetic training. So again, you know, this is, as we see, we have orthotics and we have prosthetics, training, assessment, and fitting. So again, this is for someone that's, so if it's, you know, upper and lower extremities, this could be, again, these could be hands, these could be feet, these could be partial arms, these could be partial legs, full arms, full legs, you name it, okay, for the orthotics. For the prosthetics, you know, so again, the orthotics are to help you walk, okay? The prosthetics are, again, the partial hands, the partial arms, the partial legs. So again, you know, the orthotics are to help you walk, braces and things like that. The prosthetics are what we add on to the body. And then we have the actual management or training, which is something that we'll see, especially in children that need to get a new prosthetic every couple of months as they age. Then we get to medical nutrition therapy. Again, no guidelines. We only have 3 codes. We can do this individual, we can do a reassessment, or we can do a group. 97804 is much more common. A lot of medical facilities will do this. They'll have medical nutritionists that will do like a session maybe once a month for a group of patients, maybe for a specific condition like healthy eating, things like that. Or for, you know, maybe for picky eaters and things like that. So again, these are for, more the nutritionists, but these can also be used by physicians and other qualified healthcare professionals. Then we get to acupuncture, which is paid for by some insurances. Some people swear by acupuncture and think it's the best thing that's ever happened. If it works for you, fantastic. We have two different types of acupuncture. We have the regular acupuncture. They just put the needle in, and then we have electrical stimulation, which is when they add an electrode and send an electrical signal into that area. So acupuncture is reported based on 15-minute increments of personal face-to-face contact with the patient, not the duration of the acupuncture needles and placements. Okay, so this is actually spending time with the patient. Only one code may be reported for each 15-minute increment. Use either 97810 or 97813, okay, without or with electrical stimulation. Only one initial code is reported per day. Again, if we do a separately insignificant identifiable E&M service, we can code it using modifier 25. And so again, we have to be careful with the acupuncture, with or without electrical stimulation. Then we get to osteopathic manipulative treatment. It's also known as OMT, and it is a form of manual treatment applied by a physician or other qualified healthcare professional to eliminate or alleviate somatic dysfunction and related disorders. This treatment may be accomplished by a variety of techniques. Osteopathic manipulative treatment is similar to chiropractic treatment, but the major differences between these is they go to different body areas. And a lot of times when we think of OMT, they're doing things like massage, okay? They're identifying issues and they're trying to alleviate them. But we have body regions that we have to be careful for because these are how we code it. So the body regions are the head, cervical, thoracic, lumbar, sacral, pelvic, lower extremity, upper extremity, rib cage, abdomen, and viscera. So again, where are we? So again, in this case, we need to know how many regions are involved. We have 1 to 2, 3 to 4, 5 to 6, 7 to 8, and 9 to 10. Then we get to chiropractic. This is different. So again, chiropractic manipulative treatment, or CMT, is a form of manual treatment to influence joint and neurophysiological function. Treatment may be accomplished using a variety of techniques. Again, the chiropractic manipulative treatment codes include a pre-manipulation patient assessment. Again, if they do a separately insignificant and identifiable E&M code, you may code it with a modifier 25. Now again, in this case, CMT has 5 spinal regions. They have cervical, which includes the atlanto-occipital joint, thoracic, which includes the costovertebral and costotransverse joints, lumbar region, sacral region, and pelvic, which is the sacroiliac joint region. The 5 extraspinal regions are referred to as the head, including the temporal mandible joint, excluding the atlanto-occipital region, lower extremities, upper extremities, rib cage, excluding the costotransverse and costovertebral joints, and abdomen. So again, if we're doing spinal, how many regions? Okay, and if we are doing extraspinal, 1 or more regions. So again, we need to know what type of therapy are we doing. Are we doing chiropractic? Are we doing osteopathic? The next section is, again, education and training for patient self-management. And again, a lot of times these could be used for patients that, let's say, are a newly diagnosed diabetic or something like that. So again, these are used to report the educational and training services prescribed by a physician or other qualified healthcare professional and provided by a qualified non-physician healthcare professional using a standardized curriculum that to an individual or group of patients for the treatment of an established illness or disease, or to delay a comorbidity. So again, how to eat healthy while you have diabetes, or you've just had a heart attack, how to have a low sodium diet, things like that. Now, education and training for patient self-management may be reported with these codes only when using a standardized curriculum as described below. This curriculum may be modified as necessary for the clinical needs, cultural norms, and health literacy of the individual patients. So the biggest part is that these people have to be using educational training guidelines, okay? And again, usually it is guidelines or standards established or recognized by a physician society, non-physician healthcare professional society or association, or other appropriate source. So again, for these, how many patients? Is it an individual patient? Is it 2 to 4 or 5 to 8? Now, when it comes to the non-face-to-face, non-physician telephone and online medical evaluations, these are exactly the same as the one in evaluation management, except for those are for physician services. So these are for our non-physician services. So this would be a nutritionist, this could be a counselor, things like that. The guidelines are exactly the same. So what we need to know is, has the patient been seen recently, or will they be seen shortly after the telephone call? So as it says, these codes are used to report episodes of care by the qualified healthcare professional initiated by an established patient, so no new, or guardian of an established patient. If the telephone service ends with a decision to see the patients within 24 hours or the next available urgent visit appointment, the code is not reported. Rather, the encounter is considered part of the pre-service work, an assessment and management services, procedure, and visit. Okay, so again, if they're going to be coming into the next available appointment, we can't code for telephone services. Likewise, if a telephone call refers to a service performed and reported by the qualified healthcare professional within the previous 7 days, either qualified healthcare professional requested or unsolicited patient follow-up, or within the post-operative period previously completed the procedure, then the services are considered part of the service or procedure. So again, you can't have been seen within the last 7 days, and you can't have the next available appointment to get these. So that is where we have to be careful about timing. For our online services, again, we need to use an internet resource in response to a patient's online inquiry. Reportable services include the qualified healthcare professional's personal timely response to the patient's inquiry and must involve permanent storage, electronic or hard copy, of the encounter. The service is reported only once for the same episode of care during a 7-day period, although multiple qualified healthcare professionals could report their exchange with the same patient. Now, if the online medical evaluation refers to an assessment and management service previously performed and reported by the qualified healthcare professional within the previous 7 days, either qualified healthcare professional requested or unsolicited patient follow-up, or within the post-operative period of a previously completed procedure, then the services are considered covered by the previous assessment and management of the office, service, or procedure. So yet again, they can't have either just had a visit or just had a surgery. All right, so that is what's important about these codes. The next section is the special reports and services. There are just a couple of interesting codes that we're going to look at. Again, a lot of these codes are identifying in the completion of special reports and services that are an adjunct to a basic services rendered. So this is paperwork. Code 99091 should be reported no more than once in a 30-day period to include the physician or other qualified healthcare professional time involved with data accession, review, interpretation, modification of care plan as necessary, including communication to the patient and/or caregiver and associated documentation. If the services described by 99091 are provided on the same day the patient presents for an E&M services, these services should be considered part of the E&M service, is not separately reported, because this is 99091 is collection and interpretation of physiologic data digitally stored and transmitted by the patient or caregiver to the physician or qualified healthcare professional. So this is if someone has one of those home glucose monitors, or if somebody has, a percutaneous transmitter of some sort. So again, we have to be careful. When can we and can we not code for that? One of the most important codes in this section is 99024, post-operative follow-up visit normally included in the surgical package. So when you go to follow up within your surgical package with your surgeon, including after labor and delivery, this is the code that should be used. This is a no charge, meaning they cannot charge the patient for this because, as it says, this is a component of the surgical package. So As of a couple of years ago, specifically, I will tell you, for 2017, they decided to update all of our moderate sedation. We used to actually have a bullseye that would describe moderate sedations included, but there were too many billing issues and who was billing for what. So they've decided they're going to create a whole new series of moderate sedation. Now, these codes are not that bad, and there's a table on page 697 to help you. So one of the biggest things here that we need to know is, number one, what is moderate sedation? Okay, so they tell us moderate, also known as conscious sedation, is a drug-induced depression of consciousness during which patient responds purposely to verbal commands, either alone or accompanied by light tactile stimulation. No interventions are required to maintain cardiovascular function or a patent airway, and spontaneous ventilation is adequate. So again, we use these for a lot of scopes. So we use these for endoscopies down the throat. We use these for colonoscopies. We also use these for certain bronchoscopies. We're also going to see these for short procedures. So the implantation of things like eshers for female sterilization. Small procedures where, again, we don't want to knock the patient out totally. And most of the time, people are going to be well under an hour for these procedures. Now, it goes on to tell us that these moderate sedation codes are not used to report the administration of medications for pain control, minimal sedation, which is anaxolysis, deep sedation, or moderate anesthesia care, because those all come from the anesthesia codes. Okay? So, what we need to know is the different parts of this work. So again, we're going to read about pre-service time, inter-service time, and post-service time. Now, the other thing that we need to know is an independent trained observer is an individual who is qualified to monitor the patient during the procedure, who has no other duties during the procedure. They're there just to observe the patient the whole time. So what is the pre-service work? So the pre-service work, and these codes, by the way, are separated out by whether it is provided by the same physician or other qualified healthcare professional performing the diagnostic or therapeutic services, or services provided by other than the physician or other qualified healthcare professional performing the diagnostic or therapeutic service. Meaning, if the surgeon is giving the moderate sedation, they use codes 99151 to 99153. If this is someone completely separate from the person doing the surgery, then they use 99155 to 99157. So the pre-service work includes assessment of the patient's past medical surgical history with particular emphasis on cardiovascular, pulmonary, airway, or neurological conditions. Review of the patient's previous experiences with anesthesia or sedation. So again, these are all the questions and things they're going to cover with the patient ahead of time. Family history of sedation complications. Summary of the patient's present medication list. Drug allergy and intolerance history. And focus on physical examination of the patient with emphasis on the mouth, jaw, oropharynx, neck, and airway. Again, because this is not something that we established the airway, the person needs to be able to breathe on their own. The chest and lungs, the heart circulation. So we'll come back to this in just 1 minute. And it continues. Vital signs including heart rate, respiratory rate, blood pressure, oxygenation with an end tidal CO2 when indicated. Review of any pre-sedation diagnostic tests. Completion of the pre-sedation assessment form, again, which is done for both general anesthesia and moderate sedation. Patient-informed consent. Immediate pre-sedation assessment prior to first sedation doses, and initiation of IV access and fluids to maintain patency. So that is what's included in the pre-service work. So these are all the questions, everything they're going to cover with the patient, and again, what they're going to do before they administer the moderate sedation. The inter-service work, again, begins with the administration of the sedating agent and ends when the procedure is completed and the patient is in stable recovery status, and the physician or other qualified healthcare professional providing sedation ends personal continuous face-to-face time with the patient. So if you'll notice, it's exactly the same as our anesthesia codes. It begins when they administer the agent and ends when they hand the patient off to somebody else. This also includes ordering and/or administering of the initial and subsequent doses of sedating agents. It also requires continuous face-to-face attendance of the physician or other qualified healthcare professional, and requires monitoring of patient responses to the sedating agent, including periodic assessments of the patients. Again, patients are already going to be hooked up to the EKG, the respiration rates, things like that. Further administration of agent is needed to maintain sedation, depending on what we're doing and how much time it is, and monitoring of oxygen saturation, heart rate, and blood pressure. Okay, so again, we need to know, is it the physician who is doing the surgery, or is it someone else who is actually doing the sedation? Now, the post-service work for these, for moderate sedation, they are included in the work described of each of these codes. Once conscious face-to-face time with the patient is ended, additional face-to-face time with the patient is not added to the inter-service time. However, it is considered as a part of the post-service work. Okay, so post-service includes assessment of the patient's vital signs, level of consciousness, neurological, cardiovascular, and pulmonary stability, and the post-sedation recovery period, assessment of the patient's readiness for discharge following the procedure, preparation of documentation regarding sedation services, and communication with the family caregiver regarding sedation service. Okay, so post-service work times are not used to select the appropriate code. It is the intra-service time. So we're going to go back up here. So again, this is our table. And we also need to be careful about age. Okay, so for these, we need to be careful about the age of the patient and how much time. If it's less than 10 minutes, it's not reported. As soon as we hit 10 minutes, this is where it goes. And as I tell people, this goes all the way up to 1 hour and 23 minutes. It is not likely a patient would be under sedation for much longer than that, because that's almost an hour and a half. These are for procedures that usually take under an hour to perform. So again, you always come to this area, match up the patient's age, and again, whether it is the person doing the procedure or someone other than the procedure, and matching up the codes as we need to. It looks really complicated. It's not. Now, we have a couple of home healthcare services and procedures. These are for our home healthcare nurses. And again, for these, they tell us the following codes are used to report services provided in a patient's residence. This also includes assisted living apartments, group homes, non-traditional private homes, custodial care facilities, or schools. So that's important. So again, if someone is at a dorm. So again, if they can also code for E&M, then they can only code for E&M if it's completely separate and significantly identifiable, and always use modifier 25. So that's the biggest part of it. So we have everything from prenatal monitoring, we have mechanical ventilation care, stomy care for intramuscular injections, activities of daily living, marriage counseling, fecal infection management, hemodialysis. So a little bit of everything here. Again, under home health services and home health procedures. The last set of codes, and we're almost done with medicine, is medication therapy and management services. What I want to say about this is a lot of the larger pharmaceutical companies. So we're talking about things like Rite Aid, CVS, Walgreens, if Duane Reade still exists in New York City, places like that. Most of the time, the pharmacist, part of their job duties is to explain what a patient needs. So for instance, I usually go to a CVS. There's tons near me. So when I go to CVS and I go to pick up my prescription, there's an area for drop-off and there's an area for counseling. The pharmacists, part of their contract is to do counseling to patients that have any questions about their medications. So they cannot charge for these, they cannot code for these, because these are things that are completely separate. However, for smaller pharmacies and for other pharmacist services, you may be able to code for these. It's dependent on the pharmacist and the insurance company of the patient. So, medication therapy management services, MTMS, describe face-to-face patient assessment and intervention as appropriate by a pharmacist upon request. MTMS is provided to optimize the response to medications or to management treatment-related medication interactions or complications. So again, we're looking for possibilities between interactions and complications with the medication the different medications the patients are taking. So MTMS includes the following documented elements: review of pertinent patient history, medication profile, which includes prescription and non-prescription, and recommended for improving health outcomes and treatment compliance. Again, these codes are not to be used to describe the provision of product-specific information at the point of dispensing or other routine dispensing related activities. So this, again, is something that's very specific. This is more of a sit-down, face-to-face with the patient. All right, guys, I know this ran really, really long, but I want to make sure I could get all of medicine into 3 videos for you. Keep in mind, there's a lot to medicine, and always remember that, think of other terms, other phrases to try to find these codes in the back of your book. Good luck, everyone.